It is show time.
The broadcast is now starting. All attendees are in listen-only mode.
More than ever, no more crying, we're together. Tell me you will stay, make me smile. Good morning, everybody. That was the immortal, famous, awesome, all-time historic rock and roll group called Chicago. And this is Dr. Minarcik in Chicago, actually a little suburb called Lake Bluff. Today is Thursday, It's April 4th. It's 9 o'clock a.m. here in Chicago. And I have a big 57 on my cheat sheet, which means this is our 57th 2 or 3 hour session. It'll be 2 hours today in Global Online Medical School Pathology. Hope everybody is happy today. All of our music today will be from that group, Chicago. They were a really, really, really big hit. I Googled the top 500 rock and roll songs of all time, and Chicago had 5 of them. And we're going to be playing all 5 today, and the first one you already heard. I guess this is a good time to do our test, and I see that the question box is already pretty active. So I'll start out by asking you your first question, can you hear me? And then the second question is, can you hear me very well? It seems like whenever we have problems with the webinar, which doesn't occur too much, at least not with my webinars, sometimes with the Saturday webinars, that if there's going to be a problem, it's going to be an audio problem. Believe it or not, audio consumes much more bandwidth than video. The second question is, what do you see on your screen? Yep, it's a feline. It's a tiger. Actually, it's a tiger that's made out of mathematical fractal elements. I really, really like it. And also, as a matter of fact, this is going to be the first session, I believe, in which the background screen is going to be the same as the halftime slideshow, because we're going to do a image search for tigers during the halftime. I don't think there's anything more to say. I am going to pop open the window here and look for Dr. August, and I hope that she's here today. If not, we'll look for her again during the break. I don't see her here yet, so you may not have all your questions answered instantly. She's been really spoiling us, hasn't she? Okay, let's pop open our PowerPoints and talk a little bit about what we're going to do today and maybe what we'll do, the rest of the year as well. That was our very last PowerPoint. That's what I was looking at last night to review, so I don't look terribly stupid today. Oh, let's see. We did all of these guys. We did a lot of the pneumonias. This is probably about where we are today. Where are we today? That's what we're starting with today. We're going to maybe finish up on lung today. We got PowerPoint number 76 out of 123. We may or may not finish. If we do finish, we may even go a little bit into lab because there are a lot of lung lab cases. So if we finish these, 25, 40 or so PowerPoints today, we're then going to go to our lab, and you can see these are going to be our microscopic slides that we'll be looking at in our lab. But if we don't finish today, then we'll devote probably almost the entire next session to lung lab. And that will be a great joy to me because that means we have completely finished all of the systemic pathology topics. That means by the end of the month, we should probably finish the last 2 relatively small chapters that don't have much lab, the one on environmental nutritional diseases and the one on pediatrics. So there's a very, very good chance we'll be done by the end of the month. And I don't know whether it's going to be the last day of April or the first class of May, but one of those days, our last session, we will have Dr. Vinay Kumar here, our professor's professor, talking to you about some of the things you should know about for not only pathology and for your step 1 exam, but also your life. He's very, very inspirational. So I guess this is a good time to pop in the question box and start getting down to business. If you remember, we tackled that huge topic of the regular, common bacterial community-acquired pneumonias. That was the biggest chunk of them. But we have other types of pneumonias here we have to discuss as well. And probably the second biggest category are the non-bacterial bacterial pneumonias that are acquired in the community. And there's a few of those, the biggest category of which are the viral pneumonias. Then we'll be talking about the pneumonias that are acquired in the hospital. So if you were to say, what is the definition of nosocomial? The definition is in the hospital. And we're talking about some of the ways you could have a pneumonia secondary to aspirated gastric material. We'll talk about the chronic, and by chronic I mean granulomatous pneumonias. We'll talk about some of the things that can happen, like abscesses with severe pneumonias. Then we'll talk a little bit about pneumonias in immunocompromised hosts. Then maybe in the second half we'll be able to go into lung tumors. Whether we finish that today or not, I don't know, but we're off to a good start. Even though the word atypical is used here to describe the community hospital, non-community hospital acquired pneumonias, they're acquired in the community outside the hospital. Even the word the atypical is used. It does not imply that these pneumonias are atypical cells or dysplastic or pre-malignant. It just means that it doesn't follow the classical bacterial pattern of basically leukocytes inside the alveoli. And a lot of the so-called atypical pneumonias, of which the viral ones are the biggest, it seems like the brunt of the inflammation is in the septum of the alveolus and does not usually fill that alveolus with neutrophils or pus cells. We'll be talking about some of the common types like flu and SARS. The mycoplasmal pneumonias, technically, I don't know, you could probably call mycoplasma kind of a bacteria, but you can't culture it. It's an obligate intracellular organism, and it's a very, very, very common type of pneumonia. So when we had that long list of common pneumonias at the beginning, we could include this one in it as well, except it's not technically a classical bacteria. So these things cannot be cultured. They could be identified in other ways. They could do PCR. They could do tissue culture. But regular old cultures will not isolate your organisms. And furthermore, many or most of them do not respond to the usual antibiotics. So, doing sensitivities in most cases, especially the viral cases, wouldn't really help very much. This is something I learned many, many years ago, and it does not appear in the Path books. And it would be a shame if I didn't share this with you. In all of the pneumonias that we talked about up until now, the classical bacterial pneumonias, at some stage in the acute pneumonic or pneumonitic or acute inflammatory process, you will have your alveoli here often just filled with leukocytes, neutrophils, polys. But take a look at the alveolar septum. In most cases, the alveolar septae are normal thickness, okay? So it seems like the exudate, the leukocytes leak out here. Of course, if they leak out to such a degree that the septae are actually destroyed, then you could probably call that an abscess. But now in the so-called viral pneumonias, usually, as a general rule, with some exceptions, the brunt of the inflammatory changes are in the septum. Look how thick this septum is. Look how thick this septum is. Look how thick this septum is. And also, even though the viral pneumonia may be acute clinically, more often than not, the chief cell of inflammation is something we call a chronic inflammatory cell, a lymphocyte. And if you remember, even when we're talking about the blood cells, we said that a good general rule of thumb is that bacteria elevate neutrophils and viruses elevate lymphocytes. Well, this is also true in the case of the lung, too, isn't it? So that's a good general major difference between the viral and the bacterial pneumonias. Of course, the biggest virus to cause pneumonias, we probably all had it at one time or another, is the influenza virus. There's a whole family of them. They go by various types, A, B, C. There are certain strains of type A in the early part, I guess it's about 100 years ago now, a little bit less, that caused worldwide pandemics in which a very significant percentage of the world population died. And as you might guess, most of the people that died of flu or that will die of flu, that are dying of flu right now, are probably older, more debilitated people, perhaps very, very young people, and people with some type of immune deficiency. Okay, generally speaking, influenza is survivable. So nowadays we have a whole bunch of mutations of these viruses. Sometimes they go by the name avian, sometimes they go by the name swine, sometimes they go by the name of where they came from. And the type B and C influenza viruses are usually generally limited to children. But nowadays, when there is a suspicion or an actual influenza outcropping or epidemic, the exact strains can be identified by polymerase chain reaction. So is this a classical type of viral pneumonia? I guess if that was my question, most of the smart people out there would say, no. All this is a very subtle infiltrate in the right lower lobe. And, you know, a lot of times when you go to the x-ray department and you throw these things up, or you see them on your patient's room, you can see that there's a very subtle infiltrate here, maybe even a little bit on the left as well. But these are the kind of things that the radiologist would pick up instantly, and you have to really stretch your eyes. And I think you will agree that the amount of density through this right lower lung field is a little bit more than you see in the upper lung fields, and even a little bit more than you see in the left lower lung field as well. Does this patient have an pleural effusion? The radiologist would probably tell you, probably not, because you really don't see any fluid in these costophrenic angles. In other words, these nice little points here are very sharp. Another viral pneumonia of concern, of course, any new virus, you know, the great fear is that we will have a new strain of flu or some other type of virus causing an epidemic. If you remember a few years back, I guess it's been about 10 now, in China there was an outbreak of something they called SARS. And you know, these all things have acronyms, and SARS is severe acute respiratory syndrome, to be differentiated from neonatal respiratory syndrome, or our regular old ARDS, adult respiratory distress syndrome. SARS is caused by a virus called a coronavirus, and as you might guess, the changes in the lung would look like any typical virus. If you had a patient came in, probably the blood cultures would be negative. The actual virus and the strains of it can be confirmed by a PCR. And like most viral pneumonias, the primary inflammation, like with flu or with SARS, would be there in the interstitium. And that's a general rule. Could there be a phase where there's some neutrophils in the alveoli? Possibly, but generally speaking, it looks like a viral type of pneumonia. Where are we? Okay. Here's another patient. I don't think this is subtle anymore. I think you could say, oh yeah, there's infiltrates here throughout the entire lung. And whenever you see a bunch of wires connecting to the chest x-ray, it's very likely that this patient was incumbent, laying down in bed. So now the gravitational portions of the lungs are in the posterior portions of both lobes, rather than the inferior portion of the lower lobe if they were standing up. And this is a SARS. SARS had a high, no, not in a tremendously high, but a good enough worrisome mortality to where there's still, you know, fears that outbreaks can occur again. So it's not just a matter of history. Okay, what about this crazy word nosocomial? It doesn't mean that it starts from the nose. It means that it starts from the hospital. So a nosocomial pneumonia is something that the patient acquired while he was in the hospital. And there's a lot of reasons why this might happen. Don't just blame the hospital. Don't say that they're not using sterile techniques. Generally speaking, there's two reasons for nosocomial infections, and the biggest reason is that the patients that are in hospitals are frequently debilitated. They're often lying in bed. They don't get around very much. They might be sick from other reasons. They might have had a stroke. They might have had a heart attack. They might have cancer. So basically, they're sitting ducks for organisms in that situation. They may have had a variety of catheters or things stuck into various orifices or into their mouths. Of course, these are all very well known and protected now, but they come in contact with a lot of things, you know. The probably the single biggest, without a doubt, bug that is almost synonymous with the word nosocomial is this bug called MRSA. And of course, we all know what SA stands for. That stands for Staph aureus. That's our regular staph. But the MR means methicillin resistant. So most staph should respond to methicillin. But remember, you're in the hospital. You know, methicillin is poured into patients every day like water. So on I don't want to use the word evolutionary basis, but maybe that is the right word. The bugs in the hospital have become immune. I've heard some people say, including malpractice attorneys, I've heard people say that it's almost impossible to walk into a hospital, take a deep breath, and not pick up, you know, a couple of MRSAs in your lung. You know, I'm not sure if that's an exaggeration, but when MRSA outbreaks occur outside of the hospital, you read about it in the national news, okay? So MRSA is the big one. I want you to remember that two other organisms that are big in nosocomial infections causing pneumonias and infections where other places as well are Enterobacter and Pseudomonas, okay? And Pseudomonas aeruginosa is right here at the top of the list. Klebsiella is a big one. E. coli is a big one. And remember, our regular old organism, Streptococcus pneumoniae, which cause non-nosocomial or community hospitals, are also acquired in the hospital as well. And don't forget, not only is H. flu a big bug in kids under 2, but it's also a nosocomial as one. So you shouldn't think of certain bacteria as being nosocomial or not. We got 2 or 3 on the list here that really do both. They go both ways. Okay. Let's talk about aspiration pneumonia. Now, I guess it's on the list and it was in the book as a separate entity, but it's not necessarily a different type of pneumonia. The reason why this is different is that the causative agent of aspiration pneumonia is generally, or at least initially, not a pathogen, but it's gastric contents. So what kind of person would aspirate gastric contents? Okay? Well, what about patients that are unconscious? Perhaps they've been in a coma. Perhaps they've been in a coma in the hospital. Perhaps they've been picked up at home when neighbors got a little worried as to where they were. Maybe they had a stroke. Any patient that has prolonged bed rest is at risk for aspiration. And think about it. This is not a medical question. This is a physics question. This is a geometrical question, mathematical question. If you are unconscious, prolonged bed rest, and you aspirate, what part of the lungs are probably going to be involved first? Well, they are the gravitationally dependent portions. So they are the posterior lobes, especially the posterior portions of the lower lobes, which are the most gravitational portions of your lungs. And the usual cause is aspiration and gastric contents. Could there be a secondary bacterial or viral component? Yes, and there is frequently. And I don't think there's any one big organism perhaps staph, that would be regarded as a secondary infector. But remember, there may be some bacteria in your gastric contents as well, although generally there aren't. They don't survive the stomach acid. The most likely place, posterior lobes, and especially the superior segments of the lower lobes. And of course, these are the great foolers, because the superior segments of the lower lobes, when you look at these patients on a chest x-ray, they look like they are in the upper lung field. So the superior segments of the lower lobes look like they might be in the upper lobe. So it's not unusual for, probably the radiologists are very well aware of this, but it's not unusual for you to pick up a chest x-ray and see a upper lung field infiltrate, and therefore you think it's in the upper lobe, but it's really in the superior segment of the lower lobe. And think about it, you're now pouring gastric contents into your lungs, and perhaps you have problems with clearing them. So these are the types of pneumonias that now lead to abscesses. Oh, we're going to see a good picture of that, probably in lab as well. Almost everything we see here we're going to see in lab. And I don't think I have the picture here in the PowerPoint, so let me ask you this. If you were to look at an aspiration pneumonia under a microscope, maybe there was a biopsy or perhaps an autopsy, or maybe it's a medical legal question, could you identify the specific causative agent on a regular H&E stain? Well, the specific causative agent is probably not a bacteria. But what would happen if you're looking into a lung abscess and you see a little piece of celery or some vegetable material, a carrot, or a little piece of meat? Then you generally know that stomach contents or food is the cause of that pneumonia. So can you say that aspiration pneumonias are food-caused pneumonias? I guess you could. This is typically what you're going to see in an aspiration pneumonia, and you know that because of all the wires that this patient is hooked up to, he's probably not standing up in a nice position for the radiologist. This is probably an incumbent position, and you can see a massive infiltrate here in the right upper lung field. Now, if you want to instantly call this a right upper lobe pneumonia, you may be right, or maybe even middle lobe. But the thing is, could this big infiltrate here be the superior segment of the lower lobe? Of course it could be. In fact, it probably is. So unless you have a good lateral incumbent view, you don't know whether this infiltrate is in the upper lobe, right middle lobe, or most likely, if it's a debilitated patient, the superior portion of the lower lobe. And I don't think I wanted to say anything more about this. What about the concept of a lung abscess? Okay, well, this should be the most logical thing of all. We said that they frequently occur with aspiration simply because that material is still pooling, that acid material still with partly digested food is still pooling in the gravitationally dependent portions of the lung. Could you have a lung abscess because of embolization, of septic emboli from another portion of the body? Of course you can. But no matter what causes a lung abscess, in terms of specific bacteria or previous existing pathologic process, it's preceded by pneumonia, okay? So can you say all abscesses are preceded by pneumonia? Yes. But can you say that all pneumonias will result in abscess? Of course, the answer is no. Frequently, neoplasms that are obstructing bronchi or doing local damage will result in a lung abscess as well. Okay? Think about your lungs anatomically. Do they border the esophagus, come very close? What about the spine? Are they coming close to the spine or the ribs or the pleura or the diaphragm? So would a abscess in any one of these structures perhaps result in lung abscess as well? Yes. And let's go a step further. Could a lung abscess extend to any one of these structures? Anatomically speaking, yes. Now, I don't want you to think that only certain types of pneumonias cause abscesses. The fact is, any pneumonia, which is severe enough and destructive enough, can cause an abscess. I want to go back to a picture we saw earlier, and then I'll come back to number 89. Okay, the picture we saw earlier was this one. Do you see, I'll ask you the question, what percentage of the cells in this field are pus cells, are neutrophils? Will you say 80, 90, something like that? But the remaining cells, in other words, even though this is loaded with neutrophils, you can still see the outlines, sometimes very vague or subtle outlines of the alveolar architecture of the lung. So this is not an abscess, this is a pneumonia. But what if the neutrophils here were so advanced that you didn't see the architecture of the alveoli septum anymore? What if this whole thing was nothing but neutrophils, not 90%, but 100%? Then you would call that an abscess, wouldn't you? Okay, well, that's the definition. So when we look now at this abscess, I know that if we zoomed in here, of course we can't because this is not lab, but we'll sort of see this case in lab. I think if you drew a little box right here, you would say, gee, that's nothing but pus, so you have to call that an abscess by definition. But what about down here? You would say, well, there's a lot of alveolar air spaces. Maybe there's a little pneumonia, or maybe this is normal lung. But look at the transitions. Here we have what you would say microscopically might be a few normal septum. Then up here you see that between the septum you have infiltration of neutrophils. Now you're getting to the la-la land where you don't know if there's some remnant septum or not, but certainly this big area here is nothing but a pus pocket or an abscess. Now, could this be the pleural edge of the lung? Could be, because you got some fibrous tissue here. Or could this be an attempt of the abscess to wall itself off? Quite frankly, I don't know. I would think it might be a pleural surface, because if it was an attempt of this abscess to wall itself off with a fibrous capsule, you'd probably see some of that down here as well. So this is a lung abscess. And I don't know, there's perhaps some necrotic material inside of that abscess. Could that be secondary bacteria? Could that be food? I really don't know. Okay, now the concept of a chronic pneumonia. And I almost want to apologize for this category because, throughout this entire course we've been saying, this is acute inflammation, this is chronic inflammation. We say, acute pneumonia is neutrophils. So is chronic pneumonia lymphocytes and macrophages? Well, technically yes, because pneumonias follow all of the classical principles of acute, organizing, chronic, fibrosis that we talked about many, many times. But in terms of categorization of types of pneumonia, most of the pneumonias that are regarded as chronic are chronic clinically. In other words, they persist for many months or many years, perhaps as low grade. And most of those chronic pneumonias clinically are granulomatous fungal pneumonias. So even though we use the word chronic, we mean chronic clinically. Probably the chief pattern of inflammation is not neutrophils like acute, or not even lymphocytes like chronic, but the chief pattern of body response is granulomatous. So from points of views of the classification, you can say chronic pneumonias are basically granulomatous pneumonias. I think that would probably be a good thing. So chronic pneumonias are persistent. They may be acquired in or outside the hospital. And if you look in Robbins and look at their classifications, they're basically the 4 big granulomatous pneumonias. In other words, TB, which is always at the top of the list, as well as the 3 TB granulomatous imitators, what I call the big 3 fungal systemic infections, HBC, histoplasmosis, blastomycosis, coccidiomycosis. So these are the four big chronic granulomatous pneumonias. What's the one thing in common? They're not bacterial, they're granulomatous, and they are chronic clinically, even years. And probably histoblastococcideo, the one things that these three fungal pneumonias all share in common is that they all mimic TB because they involve the lung, they involve other portion of the lungs, they're granulomatous. They may even be caseating, okay? They're probably a little bit more likely to calcify, but even TB can calcify, the granulomas can calcify. So here they are. There's your acid-fast organism inside of a few macrophages inside of a granuloma. That's the big one. Histoplasmosis organisms, histoplasma capsulatum, a fungus, are very, very tiny. You could probably put 1,000 of them inside of a macrophage, okay? Blastomycosis, the word blasto is with a B, and B also stands for big. So blastomycosis are really big spherules. If you look at the spherules of blastomycosis, they are considerably bigger than cells. Now this might be what you see before you do your silver stain. You might see a few things here that are 2 or 3 times as big as the surrounding cells. Now, coccidio are also round, fungal, yeast, spherules, but they're small. That's why I put blasto big and coccidio in small. So this one is really, really small. This one is really, really big, much bigger than a cell. And these are also smaller than a cell, but not much smaller. What are the 3 other common features is that being fungi, they may be best seen by fungal stains. It looks like this may be a PAS stain. I don't know what this stain is. It could be a fungal stain. It could be a silver stain. But generally, the fungal stains are either going to be PAS for para-iodic acid shift or some type of silver stain, of which methenamine silver is the biggest one used in the lab. So let's talk about the first one, histoplasmosis. I always laugh when I hear discussions about histoplasmosis because you can't go to a conference on histoplasmosis where the word Mississippi doesn't come in because they say, oh yeah, this is predominant in the Mississippi Valley. Well, does that mean if you go to St. Louis, you're going to see? No, look it. I actually have a map here of the area of drainage of the Mississippi River. And look, it goes all the way from New York to Canada to Montana. So what does that, like maybe 2/3 of the United States? So I really get a kick out of it when they say Mississippi. And of course the Ohio River is a branch of the Mississippi too. It's a great mimicker of tuberculosis. Technically speaking, the spores of histoplasmosis occur in bird or bat droppings in the soil, and probably on an average day we may have breathed a couple of those spores on the way to our having a lunch. We walk through the woods like I do. But most likely all of these fungal infections will be occurring in patients that are in one way or another immunocompromised. They produce granulomas, just like TB. They can often be large, just like TB. They can always be necrosis in the middle. If you want to call that caseation, you can. The granulomas of histoplasmosis, however, tend to calcify a little bit more readily, or quite a bit more readily than TB. Of course, there's ways you could differentiate with tests and cultures. And I want to show you histoplasmosis. The one thing about them is when you do a CT of somebody with histoplasmosis, look at all those tiny little calcified balls. It's not likely TB could do that. And here's the organism. Look, this is one single macrophage here now, perhaps aspirated from a lung. And all those tiny little pink things that look like they're about the size of platelets, those are all histoplasma capsulatum. And look at, here is a single macrophage as well. All of these nuclei are macrophages. Oh, that may be a plasma cell. And all of these cells have granular, foamy cytoplasm, and the granules, which are about the size of platelets, are histoplasmosis. By the way, if you were to Google this picture, if you were to Google a great picture of histoplasmosis, you'd never find it. I actually got this picture down here from one of my friends on the Pathology forum who had a spectacular case, and she shared that with us by putting it on the forum, and we downloaded it, and man, it's the best thing I ever saw, much better than Googling anything. Okay, what about the big ball? What about blastomycosis? These are also spores that can live in soil. They also, like histo, it can mimic TB. The organism is Blastomyces dermatidis, usually. And if that makes you think that there may be a primarily cutaneous variant of blastomycosis, relatively limited to the skin, granulomas, you're right, because you can have many forms of blastomycosis are limited to the skin, but the other ones are systemic. So just like TB, just like histoplasmosis, once again, like TB, you have granulomas anywhere, pulmonary, and they often calcify quickly too. And these spherules are very, very big. They're much bigger than coccidio. They're much bigger than cells. And very often they use the word Mississippi and Great Lakes in this as well. So come on, why don't you just throw this out? And of course, there can be primarily a cutaneous blastomycosis as well. And sometimes they'll differentiate different forms of blastomycosis. It's a North American and South American. And I think I'm going to show you a picture of some big balls right now. You can see even on a regular old chest film, you can see tiny little nodules. It's not like a diffuse woolly infiltrate. It's almost like calcified nodules. And there you go. There's one spherule. It looks like it's about 8 times bigger than any other cell around it. And here's that same spherule now stained with PAS, and you could get an idea for its size. Now, you want to know something? There is something I forgot to say about histoplasmosis, but I won't forget it next year, is that the one thing about histoplasmosis, more than any other of these chronic pneumonias, it loves to go to the adrenals. I don't know why. I also don't know why lung cancer likes to metastasize to the adrenals early, but it does. Often the adrenals are the first site of metastasis. Histoplasmosis loves to chew up the adrenals. So if you remember when we talked about Addison's disease, we had histoplasmosis, high on our differential list. Okay, let's go down to the third and last one. The C of HBC is coccidiomycosis. It's also a fungus. It also has spores that live in soil. It also mimics TB. The most likely genus and species are Coccidioides immitis. Okay, they also cause pulmonary granulomas. They can be large. They can be calcified. If you look at the spherules of them, though, they're considerably smaller than blasto, maybe half as size. They can actually have multiple spherules living within one macrophage. You could never do that with histo, could you? With blasto, could you? And very often, the buzzword for coccidiomycosis is southwest, because it's very, very popular in the American Southwest desert. There's probably more cases of coccidiomycosis in Arizona and New Mexico and Southern California, than the whole rest of the United States put together. Okay, that's the endemic area. And remember, all of these things, even though they mimic TB, they are also involved many, many places, besides the lung, just like TB does as well. So there's a granuloma. You've seen these before. Here's a small one. Here's one that's slightly bigger. It's the world's most classic granuloma in the world. The center portion is almost entirely macrophages. Some of the macrophages have coalesced their cytoplasm to become multinucleated giant cells. At the periphery, there may be a small scattering of lymphocytes. And of course, if this was a necrotic granuloma, there wouldn't be any tissue or nuclear recognition, probably in the center. And also remember, as these things progress, we talked about the chronic pneumonias going on for months and years even, they tend to become fibrosed. They tend to get more and more fibrosis. So you may see a granuloma in which there is absolutely no delineation of cells. It just looks like one big round scar. We'll see that in lab. And you have to look hard to determine whether that lack of cells in the middle is collagen or caseation necrosis, because sometimes it can be pretty difficult. So here's a granuloma, okay? I really did want to show you something else. No, I think we'll do that later. I think we're done with our discussion of the chronic granulomatous pneumonias. Let's move on to number 99, pneumonias of compromised hosts. I think that if you had to categorize three main phylogenetic groups of organisms that are in immunocompromised patients, not just AIDS patients, but patients on chemotherapy, patients with other inborn or acquired immune deficiencies, you would have to put PCP at the top of the list. Now, until the day I die, I'm going to be calling this Pneumocystis carinii. I know recently that the microbiologists got together and they had a little trick that they played on us, and they changed the name carinii to Girovacea, okay? I'm still going to call it carinii. And, you know, we always talked about PCP as Pneumocystis carinii pneumonia. I have a really hard time changing that to be PJP, and most of the people are still calling it carinii. The big one. This is so prominent in AIDS patients that every patient with the diagnosis of so-called full-blown AIDS, rather than just HIV positive, is presumed to have a few pneumocystis lying around. And I know that a lot of the AIDS patients, even if they don't have pneumonia clinically or radiologically, they may take inhalants of substances which are effective against Pneumocystis carinii as a preventive measure. They're assumed as having it until proven otherwise. The herpes virus, the virus in the herpes family that has a basophilic intranuclear inclusion, you know, CMV, rather than herpes simplex or herpes zoster, which have the red one. This is also very, very high on the list. If a AIDS patient has a pneumonia and it's not pneumocystis, then CMV is the next most likely choice. And of course, the fungal pneumonias, you know, the histoblastococcicidio. A fungal chronic granulomatous pneumonia is generally thought of as being due to being in a patient that has a compromised immunity. And, you know, even before the AIDS epidemic, we would do autopsies, and if there was a fungal pneumonia or fungal meningitis, or fungal infection anywhere, probably the most likely reason for that would be a patient that had been on chemotherapy, okay? Here's PCP, and I want to tell you what the buzzword is for PCP, if I was strictly trying to pump you up for the step exam. The buzzword is the word wool, W-O-O-L. And I'll tell you why. Because the pneumonias of PCP, of course, they're not lobar, and they're often not really limited. They're generally diffuse. And if you look at the infiltrate, it's not nodular, you know, like the fungal pneumonias. It's generally woolly. It's very subtle, little cotton wool radiologic infiltrates. Now, when you biopsy that, and you put under the microscope, up here you could see a pneumonia, there's no doubt about it. But when you blow up a part of this inside the alveolus, guess what? You also see wool. Only now the wool is a fluffy, red sort of exudate. And I know you all have good computers, so I got to ask you a very, very important question now. Here, you could recognize this as an alveolus. You know, I don't have to tell you that. But take a look at this little cluster of pink junk inside the alveolus. Do you see those tiny little white holes or not? Yes or no? That's a very important question. Okay, well, guess, you want to know what those little white holes are? They're this. They're pneumocystis organisms. So pneumocystis girovacii, or carinii, even though it's considered a protozoan, it's considered to be a protozoan that is kind of closely related to the fungi as well. And as you know, the fungi stay nice and black with a methenamine silver stain, and so does the organism pneumocystis. In many conferences and among residents, I've heard the term bent coins. They say when you look at this wool exudate and you see on your silver stain the organisms, they frequently look like bent coins. I don't know, that's a nice word. But I want to ask you another question. If you are looking at lung biopsies all day and you have a lot of experience, you don't need a silver stain to tell you that that's PCP, okay? When you see something like that, even if you just memorize that one tiny little area there, I really can't think of anything else that looks like it. You know when you do the silver stain, those little white holes are now going to turn black. Okay. Say a few words about lung transplantation. It was on our list before we get into lung tumors. It's a very rare thing. Lung transplants don't happen very often. Most lung patients, patients with terminal end-stage lung disease, whether it's obstructive or restrictive, usually have a lot of complication factors. Lung donors are so impossible to find. So generally speaking, those patients don't get lung transplant. Patients that have emphysema is always at the top of the list, but it's probably going to be a younger patient. It might even be somebody with childhood emphysema. If you remember, we mentioned that. A lot of the end-stage fibrotic lung diseases in a otherwise younger, healthier person that can not only survive the operation, but perhaps hopefully have many more years of good life is also on the list. Babies born with cystic fibrosis, with all the cysts in the lung, all of the pseudomonas pneumonia. These patients may not live. They may benefit greatly from a lung transplant as well. And of course, pulmonary hypertension in a younger patient, somebody that has a chance of surviving as well. There's really no such thing as reversible pulmonary hypertension. Once you have pulmonary hypertension, there's really nothing you could do to reverse it. So these are all situations in which there is no hope for medical or surgical cure other than a lung transplant. And generally we'll say younger patients. And even the younger patients, probably for every 100 of them that need it, maybe one will get it. When you transplant a lung, I got to give you the hard statistics here. We might as well go to the bad news down here. Half of the lung patients have chronic rejection within 3 to 5 years. Okay? Oh, sure, a lot of them can go a long time, 10 or more years, but generally half of the lung transplants show chronic rejection within a few years. And if you remember, when we showed you the various types of restrictive lung diseases, we talked about this one lung disease called COP, C-O-P. We said that COP is also called bronchiolitis obliterans because the fibrosis, or the organization and fibrosis that goes on frequently obstructs the bronchioles. That's probably the most likely pattern that you'll see. Another thing is for a patient to have this type of infection, because remember, a lung transplant patient is also an immunosuppressed patient, aren't they? Because they're on long-term immunosuppressives. So besides the usual bacterial and viral, you're going to get all of the pneumonias that are so common in the immunocompromised patients, like fungi, like CMV, and like PCP. These are 3 things from our list, as well as the regular bacterial ones. Acute rejection, not very common like most transplants, but if it happens, it's going to happen within weeks to months. Okay, that's considered acute. Chronic is generally in the stage of years. And the last thing we'll show you is a lung transplant. It's somebody that has a chronic rejection, the most common pattern in chronic rejection. We showed you this picture before. You could see that these epithelium here represent a small bronchiole. There's no cartilage, so I know it's a bronchiole rather than a bronchus. And you can see that it's obstructed by what looks like organizing inflammatory tissue and fibrous tissue. That's why COP, which is the pneumonia of chronic lung rejections, is also called bronchiolitis obliterans, because this bronchiole is being obliterated by that organizing inflammatory tissue. Okay, let's take a look at the clock. You know, we have a lot to say on lung tumors. I'm going to make it as painless as possible. We could take a break now. It'd be an early break, but that way we could really get into it afterwards. So this is a good place for a break. We only have, according to my mathematics, about 15 PowerPoints left. Maybe we'll be able to start the lab, maybe not. There's no reason to rush, because we're going to do almost all of these lab cases no matter what. We certainly won't be able to do them today. We might get to a couple, but if we have to spend the entire next session on lung lab cases, we will. So let's take our break now. And once again, all our music will be from, you know, the rock group that is named after the city that I live in. And just as though we see our fractal tiger on the screen, we'll be looking at a lot more tigers on the slideshow. So, ladies and gentlemen, we will see you in about 10 minutes.
star. Yeah, I got to get you in my life, mama. Got to get you next to me. Yeah, all in the beginning. Oh, that's just a start. Yeah, 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 yeah. and singing for a song. Will you help him change the world? Can you dig it? Yes, I can. And I've been waiting such a long time for today. Slow motion riders fly the colors of the day. A bronze man still can tell stories his own way. Listen, children, all is not lost, all is not lost. Oh, no, no. Funny days in the park, and every day's the 4th of July. Funny days in the park, and every day's the 4th of July. People reaching, people touching, a real celebration. Waiting for a song. Waiting for a song. Yeah, I want it, really want it. Can you dig it? Yes, I can. And I've been waiting such a long time for the day. Yeah, yeah,
Wow. I just love that group, Chicago. They're just awesome. You know, usually at this time of the week, I'm 1 hour away from happy time because at the next hour I'll feel really great because my work of the week is done. Of course, I'll probably have about 8 more hours of movie crunching to do, but at least the show will be over. The reason why I picked Chicago is because that's not just because they're the best rock and roll group of all time. It's also, they remind me so much of my wife who passed away about 8 years ago. First of all, we're both from Chicago, and when we met and started dating, they were, of course, the kings of rock and roll, and they still are. She also happened to have claimed that she had a double date with Jim Pankow. Now, Pankow was one of the leaders of the group Chicago, greatest rock and roll groups. She said that she double dated with him. I wouldn't be surprised if he actually asked her out on a date, but she was very polite. She told me that she just double dated with him. Also, that last song that you heard, Saturday in the Park, that's the song that I can remember from our wedding day. You know, sometimes when guys get married, you know, they think back, you know, 35, 40 years later. Actually, it's over 40 years now. They can only remember one thing. Well, I remember a few things, and the one thing I remember is that when we were in the limo on the way to the reception, they played this song. The song was on the radio, Saturday in the Park. So this reminds me of her as well. And that's why I'm happy now, and I don't have to wait for 1 more hour. So this was a good break, and it leads us into the final topic on lung tumors. You know, the basic algorithm all pathologists use is when they either think about diseases or look at diseases under a microscope, is they always think in terms of 3. Like there's 3 kinds of diseases of anything, you know, not just lung. First they say, well, is the disease or the tissue that I see in front of me infiltrated with some type of inflammatory cell? Or do they say, is it some kind of degenerative or non-inflammatory process? And then, of course, the third thing that comes to their mind logically, but it's usually the first thing that occurs in terms of their job, is the concept of neoplasm. because if you want to say all diseases are either degenerative, inflammatory, or neoplasm, neoplasm is always at the end, but in terms of a pathologist's job and energy, it's usually at the front. And usually when pathologists talk about diseases, they spend 90% of the time talking about tumors and 10% of the time talking about everything else, because that's their job, to diagnose and classify tumors. But this will be relatively short. We could go into a massive classification of lung tumors. Just about every type of possible tissue tumor in the world you can see in the lung, either benign, malignant, primary, metastatic. But as a general rule, we talk about primary lung tumors. You know, patient comes in, they have a tumor in the lung. Most likely it's going to be malignant. 90% are. And most of those are carcinomas. Yeah, they could have a benign tumor of any type of tissue that normally populates the lung, or a malignant tumor, either primary or secondary. Of course, it's probably just as likely that it will be secondary as it is primary. If that tumor is composed of cells of epithelial origin or appearance, or perhaps what we would say ectoderm or entoderm derived, we would call that epithelial. If it comes from mesodermal components, connective tissue, we call those mesenchymal, benign or malignant tumors. Lung tumor is the biggest killer in the United States. It's the biggest cancer killer. Now, I know what you're thinking. You're thinking, well, you already told us that prostate was the #1 prevalence in men and breast was #1 prevalence in women. So how could lung be the biggest killer? Well, the reason why is because it's not as detectable as some of the others. And usually by the time a lung tumor appears as a mass or a clinical symptom, it's been there for a long time, and good chance it may have already spread. Hate to tell you this, but you know, there's a lot of people that, know people that have lung cancer. The hardcore facts are, don't go broadcasting this too much, but only 15% of people diagnosed with primary lung malignancies are alive 5 years later. We all know the major cause, tobacco, and we're not going to go into all the mechanisms and carcinogenesis and promotion and initiation factors. You know that polycyclic aromatic hydrocarbons are the things inside of tar. You know that there are benzpyrenes, anthracenes in there. We know that even radon and other isotopes can be a factor. There's also a common progression of genetic mutations, which we've dealt with already, and we're not going to go into that again either. The MYC, KRAS, EGFR, HER2/neu, these are all commonly observed mutations, loss in function or mutations of regulatory growth genes that occur commonly with various types of primary lung malignancies. When you talk about lung cancer, the type that is always at the top of the list is squamous cell carcinoma. So let's use that as a model, okay? If you wanted to go to the pathogenesis of a lung cancer, probably the first place to start would be up here, in which you could see a bronchus. And the bronchus, like any bronchus, has pseudostratified ciliated columnar epithelium, maybe a few goblet cells. I don't see any cartilage here, but this is a bronchus. This is as normal as could be. The process of carcinogenesis and the progression of, or the cascade of gene mutations might give you a histologic appearance where at first there are just some inflammatory changes, perhaps an increase in the cells, the reserve cells or the cells at the base of the mucosa that are giving rise. Still not exactly what you would call squamous metaplasia yet, but how can you have a squamous cell carcinoma as your most common type of lung cancer if you don't normally have squamous cells in the lung? Well, the reason is that these bronchial changes then show squamous metaplasia. This is clearly squamous metaplasia. It's not keratinized, but this is a bronchus. This metaplasia with further progression, perhaps years even, of influences, not just chronic inflammation itself, but the things that are causing the chronic inflammation, like cigarette tar, for example, will show an appearance like this. Now, once this squamous metaplasia has enough atypia, and you can then say, maybe some of these cells now look bigger and darker. This would probably be something called mild, or probably most likely moderate squamous dysplasia. But by the time you get to here, the cells are so unorganized and dark and irregular, and not much attempt at a maturation from the basement membrane to the surface. You might say, well, this might be carcinoma in situ. And that's still not a killer, is it? Because it's limited to the good side of the basement membrane. Of course, with time and with continued appearance of the carcinogens, you can eventually get something like this. And of course, these red cells are squamous cells, and the white material is connective tissue. So now you could see infiltration. Okay, and this could be going on for years before the patient develops symptoms, before he might develop hemoptysis, before he might actually have a mass apparent on either CT or chest x-ray. So this is a classical pathogenesis. This is something we've known for many, many years. The thing that I think has a lot more work to be done on are the predictable cascades of genetic mutations appearing at different steps. For example, let's say that all this stuff happened, but a certain mutation is necessary to make it invasive. Because remember, invasive is the definition of cancer. And if somebody only had carcinoma in situ, they'd never die from it. Or metastasis, for example. These are the things that have to be further understood. Let's make this very, very, very easy. Remember, when we talked about lymphomas, we said there's only two kinds. There's the non-Hodgkin's and there's the Hodgkin's. Well, guess what? With lung cancer, there's only two kinds. There's non-small cell and there's small cell. And even though, just like in non-Hodgkin's, it was the most common type of lymphoma, non-small cell is by far the most common type of lung cancer. So what do these non-small cells all have in common? Well, they are all epithelials. They might actually be differentiated enough to form these squamous features that we saw in the previous slide. They can be glandular. These are still epithelial. Or they could be still carcinoma cells or epithelial cells as identified by microscopy and all kinds of immunostains, but they don't form glands and they don't look squamous. So these are often called large cell. Often they're also called large cell undifferentiated, but this is the family of non-small cell. I can tell you with experience that even though there's three different patterns, the general management in terms of surgery and chemo and radiation, the responses are very, very similar. But the small cells, which are a small fraction also of the lung cancers, are a whole different animal. These are not epithelial cells. These are neuroendocrine cells. They're ultimately derived from neurocrest. And I'm going to tell you right now the good news and the bad news about small cell. Bad news is it's the worst kind. It has the worst biologic behavior, the quickest spread. When you see it even as a relatively small mass in the lung, chances are statistically it's already metastasized. They give prophylactic brain radiation to small cell carcinoma patients, even if there's no evidence for brain metastases. The good news is, if you think there could possibly even be good news by now, the good news is that they are frequently the most drastically responsive to chemotherapy. Oh yeah, there's a lot of regimens and a lot of studies showing some responses, but the response to small cell, to the various small cell, often combination regimens, in a large number of cases is often very dramatic. Okay, now if you want to look at the big list, you can, but I am not a big fan of big lists. We've already talked about squamous. You could have small cell, which is not epithelial. You could have, also, you can have a carcinoma that has both small cell as well as epithelial, like either squamous or adeno. If you have an adeno, you can have various adjectival subtypes. They can look bronchoalveolar, they could look solid, they could look glandular, they could look papillary, they could be mucinous. They could be every type of adjective you ever put before adenocarcinoma. We talked about the large cells. They're also large. But you can also have a larger type of cell that's also in the small cell category because they're also neuroendocrine cells. And furthermore, a carcinoid tumor, the tumors of carcinoid are also derived from that same neuroendocrine or neural crest thing. So if you want to say carcinoid, large cell neuroendocrine, and your classic small cell are all in the small cell category, even though one of them is large cells, and the rest of them are non-small cell. Now, I hate, as an apology to that last big laundry list, I'm going to go back to your basic histology again. We've seen this, and we will see this in lab probably in the next session. But once again, Luke, use the force, okay? Just look at your histology, visualize it. You have a bronchi. Some of them are surrounded by cartilage, the bigger ones. The cells are pseudostratified. They can be squamous metaplastic. You have basically, the more you get towards the smaller bronchi, the flatter the cells become, and they go from columnar to cuboidal to even squamous by the time you get to the alveolus. You have blood vessels. Just about every type of normal, you have macrophages. You have smooth muscle. You have cartilage. You want to know something? One of the most common benign tumors of the lung is actually a tumor of the cartilage of a bronchus. It's called a hamartoma. So once again, just visualize your cells and the components and think that any of these cells can proliferate as a benign or a malignant fashion, and that's how you classify lung cancers. And then also remember that the lung is the #1 favorite site for metastases. So cancers anywhere in the body can go to the lung, and they go to the lung more than any other place, even more than the liver. And I want to tell you that when you are dealing with sarcomas or malignancies of connective tissue, like osteosarcoma, leiomyosarcoma, fibrosarcoma, blah, 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 the lung is like their lymph node. A metastasis from a sarcoma usually goes to the lung before it goes anywhere else. And people that die of sarcomas usually present with pulmonary problems, like a cold or a cough that just doesn't go away. So they go to the doctor when they wind up getting worse rather than better, and they see little balls all over the lung and maybe the liver too. Here's a large main stem bronchus on the right and on the left. And classically, in a squamous cell carcinoma, we said that this was preceded perhaps by many years of chronic bronchial inflammation, squamous metaplasia, squamous dysplasia. So theoretically, a squamous cell carcinoma, which is more centrally located, around the center portion of the mediastinum, is logical because that's where the large bronchi are. Now, an adenocarcinoma can technically originate anywhere, but if you remember, the adenocarcinomas are generally more likely to occur peripherally in the lung. Of course, anything is possible. You can see that this squamous cell carcinoma, which may have originated in a large bronchus near the center of the lung, has gone all the way out to the pleura. If you have done a sputum on this patient, you would see the spindly type cells with large, dark, atypical nuclei. I guess if you show this to a cytologist and you told her that this is where it came from, she would say, oh yeah, that's an obvious cancer cell. But if you were to just say, hey, this is a sputum I got from a friend of mine, can you look at this cell? They would say, well, it's very atypical. I can't say it's cancer for sure. So once again, we have to use a lot of intellectual honesty. Here's another group of cancer cells. Look how much bigger they are compared to your, maybe 15 centimeter Neutrophil over here, you know, they're twice as big. They don't have much cytoplasm. And in these, you can't even say, in all honesty, that they look squamous. You could say they're undifferentiated. You can't say they're glandular. But this is a classical appearance of cytology and gross specimen of squamous cell carcinomas. And the radiologist will always tell you they are generally trained to say squamous in the middle, adeno at the periphery, but there are many, many exceptions to that. I'm going to show you right now a classification of all of the common types of lung cancer. And I think you're going to get it right away, because I think you have enough experience to know that when you look at the northwest here and you see a cluster of cells and it has a little whorl inside of it, I'm going to ask you a question about every one of these slides. Is this squamous, adeno, large cell, or small cell? Yeah, you all know it's squamous. Now, what about this carcinoma in the northeast? Is this squamous? Is this adeno? Is this large cell? Or is this small cell? You all know that's adeno. Now, take a look at the southeast. They look like epithelial cells, but they're not really forming glands, and they certainly don't form squamous either. So same question, A, B, C, D. Is this squamous, adeno, large cell, or small cell? Yeah, this is large cell. And they're just called large cells because they're not necessarily larger than these cells, but they're undifferentiated. And remember, the oat cells, or the small cells, are also undifferentiated, but they're a lot smaller than the large cell. So, let me ask you now the obvious question about the Southwest. What's the diagnosis? You all know I'm being sarcastic. This is small cell. At first glance, when you look at small cell, you can see they're small cells. They don't have much cytoplasm. So if you look at them quickly, you might say, oh, this is a bunch of lymphocytes. But the big, big, big difference between small cell carcinoma and lymphocytic infiltrates is that they frequently show necrosis. Now, you don't see much necrosis here. I think you'll agree. Maybe there's some fragmentation of the nuclei there. I don't know. That would be necrosis. But the other thing that they show, the buzzword, is called molding. Even if you have a bunch of lymphocytes infiltrating an area or forming a follicle, when you look at the nuclei, they're all round. But in small cell carcinoma, the nuclei compress each other. That's what they call molding. So, let's make a long story very short. The Southwest here is small cell, and these other three things are non-small cell. And even though it's nice to say, tell the doctor, oh, this is adeno rather than squamous, or this is large cell, non-small cell rather than squamous or adeno, I could tell you when it winds up to the patient's treatment in terms of radiation and chemo, the non-small cells are very, very, very similar. And I know that there are some regimens that are going more for adeno rather than squamous, but overall, the survival statistics, the radiation rationale, the chemo is basically all the same for all the non-small cells. Okay, here's a big thing. You know, I have to apologize whenever I show you a PowerPoint that's more than 25 words, but the TNM for lung, if you look at some of the classical division points here, this is not that horrible after all. T stands for tumor involvement, you know, going from 1 to 4. N basically stands whether there's no nodes or some nodes, from N0 to N3. And then it's very easy for Mets. M0 is no Mets. M1 is metastases to things other than lymph nodes. And we've already told you that a great place for them to go is adrenal. Another great place is anywhere else in the body. So if a tumor is less than 3 centimeters, it's called T1. If it's more than 3 centimeters, it's called T2. But if it involves the chest wall, you can call it T3. Now, if it involves critically important organs like heart, great vessels, trachea, esophagus, or even direct extension into a vertebral body, that's called T4. Now, you can have a lung cancer causing direct infiltration into a vertebral body, but that's not metastatic. That's direct extension. Now, for the lymph nodes, N0 is no mets. N1 is metastases, but only to lymph nodes on the same side. And N2 is metastases to the same side, but also deeper into the lung, like mediastinum or subcarinal. And of course, N3 is contralateral metastases. And of course, the M's are the easiest of all. It's either M0 or M1. So that's the T and M. Very important in staging. This is all anatomically logical, I believe. What are the local effects of lung cancer? Well, we've already said it could obstruct the bronchus, so cause atelectasis, right? If something is not ventilating, it may become inflamed. It could have an abscess, okay? Very frequently, when you have a lung abscess, after you treat it with antibiotics and it clears up clinically, you see the tumor after the abscess goes away. So you can have an airway obstruction, okay? Very often, the tumor creates an inflammatory reaction where the macrophages are attacking it and chewing it up, and it has what they call a lipoid or a lipid. I said lipid pneumonia, but I think lipoid is probably also used. So pneumonias are usually and frequently the effects of cancers. Now let me ask you this. Is the opposite true? Does a routine pneumonia cause a cancer, usually? Yes or no? Absolutely not. But the other side of the coin, does a routine cancer usually cause some type of pneumonic inflammation? And of course the answer is yes. You can have a pleural effusion, and of course the difference between a pleural effusion from lung cancer and a pleural effusion from either heart failure is that you have tumor cells in it, and that you also may have a thicker type of fluid. It may have a higher specific gravity, it may have a higher LDH, and of course, anytime you tap a patient's lungs and you got that fluid there, even if it's just somebody that has congestive heart failure, it's certainly going to be looked at for cytologic evidence for tumor cells as well. If the cancer invades the laryngeal nerve, the recurrent laryngeal nerve, remember that little thing that wraps around the arch of the aorta? That could cause hoarseness. If it involves the esophagus, it could involve dysplasia. If it invades the phrenic nerve, also in the chest, it caused diaphragm paralysis. That's not good, does it? Because now we have another reason for decreased ventilation and setting up the setting for more pneumonia. Could it do a direct invasion into chest wall? Yeah. And remember, even though it's going to the rib, that's not necessarily metastasis. That's not high stage yet. That's still considered T4 rather than M1. We talked about compression of the superior vena cava, general facial and upper extremity dusky cyanosis. We talked about Horner syndrome if the tumor invades the sympathetic ganglia. And of course, remember, there's also another big thing in that chest called the heart. So a malignant effusion of the pericardium is generally considered to be lung cancer until proven otherwise, because the studies have shown when you have malignant pericardial infusions, I think maybe 70 or 80% of the time, it's usually from lung. What do you think the second most likely is, by the way? Just out of curiosity. Anybody want to take a guess? It's breast. Okay. Could that malignant infusion also cause a tamponade? Yeah, so these are all the local effects. Now, let's talk about the systemic effects, okay? So a systemic effect of a neoplasm generally has the term paraneoplastic syndromes. And we talked about, when we talked about cancer, many different types of paraneoplastic syndromes. Now, the most common type of paraneoplastic syndrome is the result of a lung cancer cell secreting a hormone or a hormone-like substance. They may not be exactly the same number or type of amino acids as you would see in ACTH or PTH or ADH, but it could be very, very close. It could have the same effect. So if lung cancer cells secreted an ADH-like substance, would you expect an inappropriate ADH syndrome, the ectopic production of ADH? Okay. What about patient with Cushing's syndrome? Not because of a pituitary or an adrenal disorder, but because of a lung tumor cell producing an ACTH-like substance. Or hypercalcemia. You can have hypercalcemia with metastatic disease simply because the tumor is chewing up all that bone. But what if it's hypercalcemic because the tumor cells are producing a parathyroid hormone-like substance? Or even a calcitonin-like substance, which would be hypocalcemia. Lung cancer cells have been known to produce a variety of gonadotropins or serotonin bradykinin-like substances. And I don't want to go into the complex description of which types of lung cancers are more likely to produce which types of ectopic hormones, because both the small cell as well as the non-small cell cancers can produce a wide variety of things. And true, the small cells, because there are neuroendocrine cells, they might produce one, some more than others. But these, let's just say that lung tumor cells in general, you know, whether they're non-small cell or small cell, 5% of the time result in a paraneoplastic syndrome because of ectopic hormone-like production. So what are the rest of the tumors of the lung? There you go. Look at your histology, look at the cells, and ask yourself, can these cells theoretically proliferate in a benign or malignant fashion? And of course the answer is yes. So it's a big, big, big long list. I think of all the organs of the body that have the greatest number of different kinds of tumors, both primary and metastatic, you know, lung is at the top of the list. And we said that the lung, when a patient has metastatic disease due to any tumor, what is the single most likely organ that it metastasized to? And the answer is lung. And some people might say liver. And the liver might be the first site of metastases for the carcinomas or the malignancies of organs that are drained by the portal system. You know, the colon, the small bowel, the pancreas, you know, the stomach, the spleen, technically. But in general, lung, most common site for all metastases. And I want you to think of the lung as being the lymph node for sarcomas. Just like the liver is the lymph node for GI adenocarcinomas, think of the lung as the lymph node for sarcomas, because the general rule is, with some exceptions, sarcomas or malignancies of connective tissue usually go to the blood vessels before they go to the lymph nodes. So it's generally the first choice for metastatic sarcomas. We're done with lung. Let's move on to the covering of the lung, the pleura. If you want to say that pleuritis is exactly the same as pleurisy, you can, because they are both either primary or secondary or any type of inflammation. You know, they might result in a friction rub when you hear it with your stethoscope, if enough is involved. Most of the cases of pleuritis are also associated with inflammation of the underlying lung as well. Pleurisy is used more as a clinical term. You know, patient has pleurisy, whereas a pleuritis is more of a diagnostic term, but they're generally interchangeable. Could you have air in the pleural space? Of course you could. Could you have an effusion in the pleural space of fluid? Of course you could. If it's water, basically, transitate, you call that hydrothorax. But nobody calls it a hydrothorax. They call it a pleural effusion. If you have blood in the pleural space, that would be called hemothorax. It could also be called a bloody pleural effusion. Could you have chyle, you know, in the pleural space? Of course you can. That would be called chylothorax. And look at all of these general terms that we used, hydro, hemo, chylo. Look at, they also apply to the pericardium and the peritoneum as well. So do the 3x3 matrix, and I don't want to have to recite all 9 of them, but a bloody effusion in the peritoneum might be called a hemo peritoneum. Of course, most people would just substitute the word peritoneum for ascites. So, chylous ascites. Could you have a chylous pericardium? I guess you could. Could you have a hemopericardium? Could you have a hydropericardium? All these 9 things are possible. And remember, all of these mesothelial lined spaces, whether they're pleural or pericardial or whether they're abdominal, they are lined by mesothelium, both on the surface of the organ, generally given the name visceral, as well as the outside of the theoretical space, which is generally called parietal. So could those mesothelial cells proliferate in a benign or malignant fashion as well? Yes. So mesotheliomas are just not in the lung. They could be in the pericardium. They could be in the abdomen. They could be in any place where there's mesothelial cells. Let's look at the common cause of pleuritis. They're generally the same general organisms that cause pneumonia. Bacteria, viruses also cause pleuritis. There are some that are more specific for the pleura. And lung that's infarcted, in which there is compromise of both the pulmonary as well as the bronchial or systemic circulation, is more likely to be involved peripherally. So, you know, when a pathologist, let's say you were a blind pathologist, but you had to diagnose a pulmonary infarct, well, you would just, you know, cut open the body, you know, and then yank out the lungs, and then start feeling the external surfaces of the lungs, because infarcts are always subpleural. They're always at the periphery of the lung. Lung abscesses can cause a pleuritis because that inflammation can extend to the pleura. If there is primarily a collection of pus in that pleural space, rather than water, rather than blood, rather than chyle, I guess you could call it a pus effusion or a leukothorax, but the name that's given is empyema. So empyema is a collection of pus, P-U-S, in the pleural space. TB is a big, single biggest cause of a pleuritis, you know, worldwide. The collagen diseases, the systemic collagen diseases, like rheumatoid, like lupus, like dermatomyositis, like scleroderma, or better called progressive systemic sclerosis. These are all things that can cause fibrosis anywhere. And of course, the pleura is not excluded. Finally, probably one of the most common causes for inflammation, even a significant fibrinous inflammation of the pleura, just like a significant fibrinous inflammation of the pericardium, is due to renal failure. So you have to remember that as well. And can metastases seed the pleura? Of course. The pleura is much richer in lymphatics than the rest of the lung. And that's why last year, when you did your anatomy dissections, and you looked at somebody's lungs and they look so black, and you go, oh my God, did he live in Pittsburgh? Did he smoke cigarettes? You then cut open the lung, and you can see they're pretty pink underneath that black area. So the lymphatics are richest in the pleura. What about air in the pleural space? Well, theoretically, if you were to take or measure the potential pressure, air pressure in your pleural space. Even if there's no air in there, it's lower than atmospheric pressure. It's a little bit low. So the general rule is if there is a connection between the atmosphere and the pleural space, the direction of airflow is going to be going into the pleura. So you can have an open chest wound and a stab wound or gunshot wound, or you could have something that was closed, like perhaps a ruptured bleb. Now that bleb has atmospheric pressure, but if it ruptures, it's now going into a lower pressure area. So the general rule is if there is a potential valve type process going on, the valve is going to be in the direction of going into the pleura, simply because of pressure differences rather than out of the pleura. And the more air, once that space is opened, that goes into the pleura, you can then have a concept of a tension pneumothorax, where you have progressively more and more and more pressure. Of course, the treatment for significant pneumothoraces, and very often the radiologists quantitate them by percentages. So example, a 5 or a 6 or a 10 or a 15% pneumothorax means only, 10%, small percentage of that space is filled with air. Those frequently they do nothing to. They just let them reabsorb with time. But if it's a significant amount, 50, 40, more than 50, they stick a needle in there and they suck the air out. And, you may be doing that someday. So in chronic lung disease, we talked all about the complications. But what about that big bulla or bleb now rupturing? Well, that's an example of a closed pneumothorax. Besides perforating injuries, and probably the single most common cause nowadays of pneumothorax is people that go into the hospital and they get needle biopsies for lung tumors. Because when you introduce a needle into that tumor, you have to go through the pleura, and you theoretically have an open space there. And if you're trying to suck out cells from the lung, you may also be putting air in there as well. And those are usually small. They are usually not needed, to go through a separate procedure, but they are very, very, very common. It's not unusual for a radiologist to be proud of himself because he just sucked out a nice bunch of diagnostic cells with a needle. And he'll say, oh yeah, well, it was only about a 3% pneumothorax. And the patients usually are not symptomatic. But remember, the pleural surfaces are the only places that have pain fibers. You could have a massive destructive process involving a whole lobe of a lung, but if it doesn't involve the pleura, you won't feel any pain. The pain fibers are in the pleura, both visceral as well as parietal. We've already talked about the concept that you could have a transudate or hydrothorax, most common cause, heart failure, okay, but any pulmonary edema due to any other cause can also result in transfer of fluid from the alveolar, to the pleural compartments. If you have a pneumonia or a tumor, that fluid is not like pure water, but something we call exudate. It might have a lot of cells in it. It might have a high specific gravity. It might have a high LDH content because LDH is a cellular enzyme. There are a lot of cells, there's a lot of LDH. Or for the same reason, you can have a lot of blood in there as well. Perhaps pulmonary infarct produces a lot of blood. Obstruction of the thoracic duct, okay, can produce a significant amount of white fluid, lymph called chyle. And I'll tell you something right now. If you ever do a abdominal tap or paracentesis, or you ever stick a needle to draw out pleural fluid, and it's very nice and white, looks exactly like milk, then that's considered a chylothorax until proven otherwise. It's not a funny bacteria that causes some white pigment. So white fluid coming out of your tapping needle in the abdomen or in the lung is probably going to be chyle. Very, very last topic now is to talk about tumors. And remember, we said that mesotheliomas occur in any place where there's mesothelial cells. Okay, they could be benign or they could be malignant. But I want to tell you something. When you have a report come back from your pathologist and it says mesothelioma, it's probably not going to have the word benign or malignant in front of it, because most of the mesotheliomas are just called mesotheliomas, which means that the way that the cells look does not usually predict its biologic behavior. So even cells that look like normal mesothelial cells can be causing massive compression of the lung. So mesothelia is one of those relatively tumors, vague tumors, you know, like carcinoid, that usually will not be preceded by the word benign or malignant. Could they occur in the visceral, pleura, pericardium, or peritoneum? Yes. Could they originate in the parietal, pleura, pericardium, peritoneum? Yes. Now, I want to tell you that mesotheliomas of the lung might appear as nothing more than a little thickened fibrous nodule, or they can appear glandular as well. They're very, very common, and they usually do not cause widespread growth and compression of the lung. If they do, it's very likely that the causative or the exposure of this was asbestos. Now, are there mesotheliomas in people that had never exposed to asbestos? Sure. If you looked at everybody's lungs that lives in a big city, might you find a couple of ferruginous bodies? Yeah, probably yes, okay? But the connection between asbestos and mesothelioma is very, very, very well established. And also, asbestos has also been implicated with some of the primary lung cancers, which are not mesotheliomas either. Now, the thing you should remember about the morphology of a mesothelioma is that even though this mesothelioma here looks like it occupies about 2/3 of the thoracic cavity, do you notice how it's not really infiltrating irregularly? It's almost like it's becoming thicker and thicker and thicker and compressing the lung from the outside. So very likely when you look at a mesothelioma and it looks like there's some big fibrous encasement causing the viable pulmonary parenchyma to be smaller and smaller and smaller, and this compression is 360 degrees all around. This is the classical feature of a mesothelioma. Now, let me ask you another question. Do you need a microscope to tell you whether this is a benign or a malignant mesothelioma? And I got another piece of good news for you. If you did look at these cells in all areas, they might look perfectly benign. You know, so let's go to the last concept of mesotheliomas, and then we'll feel like we covered everything well. Let's look at some microscopic pictures. Mesothelial cells, when they form tumors, they look epithelial. Now remember, mesothelium is mesodermally derived epithelium. It's not true epithelium. It looks epithelial. One of the mesotheliomas we're going to see in the lab looks exactly papillary, like an adenocarcinoma. So, from a pathologist's point of view, or from the patient's point of view, the differentiation between mesothelioma and carcinoma is vastly important. It might mean, you know, a $500,000 settlement, you know, from a lawsuit. And if you drive down any superhighway in the United States, you're going to see a billboard with some lawyer saying, "Do you have mesothelioma? Call me." You know, this is a big, big money maker for the vicious, you know, maggots that we call lawyers. So here are cells that look epithelial. Now, how do you know whether these are mesothelial cells or whether they're epithelial cells? Well, there's a certain expression of a protein called calretinin. You see that? Calretinin? Mesothelial cells express calretinin, but epithelial cells don't. So that's a very, very easy thing. Now, they express it most of the time. Sometimes they don't, but most of the time do. So when you see a tumor, you're not sure whether it's mesothelioma or carcinoma, you get a calretin. If it's positive, it's mesothelioma. Another thing is that this is a normal electron micrograph of a glandular cell. Now, you know that many of the epithelial glandular cells have a few little feeble or polite-looking microvilli. You know this is a microvilli because it projects off of the cytoplasm. But classically, mesothelial cells are microvilli jungles. They are very, very, very rich. Now, could a poorly differentiated mesothelioma or a malignant-looking one not have as many? Yes. But those are the two features to differentiate. Carcinoma, few microvilli. Mesothelial cells, many microvilli. Carcinoma cells, negative for calretinin. Mesothelial cells, mesothelial cell tumor cells, positive for calretinin. We're done. And I'm very happy. We did lung is a very important thing. Technically, we're at the very, very end of our discussion of systemic pathology topics. It's already 10:57. I kind of figured we wouldn't get a time, but we're going to have our fourth discussion now next week in exactly 5 days minus 2 hours. We're going to look at maybe all of these in lab. We're going to spend the entire day, or maybe most of it, yeah, probably all of it, just looking at, lung conditions. It's a very nice group of slides we have here. So you can look forward to that. So, you don't have to comb your hair or wear your suit to the next class. You can just throw on your, your lousy lab coat, and we'll spend the whole day having fun in lab. And we'll see you in 5 days. Now, the last Chicago song that we're going to play today, I don't have the words to it, but it's a beautiful song. And we will say that at the end of today, we're done with all of the Chicago songs. So unless somebody wants to make a quick comment in the comment box, which I'm looking at, we'll say, rock on, buzzards. We'll see you in 5 days.
Time goes on, I realize just what you mean to me. And now that you're near, promise your love. There
Rock on, you buzzards.